Hi, hello, welcome back. Let us discuss an interesting case of seizures. This is a 12-year-old child with seizures, axial T2 weighted imaging. Please write down your findings. Is coronal flare and T1 inversion recovery images. Please write down your findings. This is post-contrast T1 images. Write down your findings. These coronal flare images. Again, what is this abnormality you are seeing in the coronal flare image? This is axial T2 at the lower level. What is the pathology seen in this? Okay, so what is the diagnosis? This is an interesting case because there are multiple pathologies. Any one of it could have contributed to the seizures of this patient. Let us come to the first one. The first one you are seeing in the red circle is similar to the gray matter. So it is looking like a mass-like malformation, but definitely if you carefully see, and it is definitely not a malignancy or neoplastic pathology. It is following the gray matter signal in all the sequences, like in flare or T2 or inversion recovery. So this is a classical nodular peritrigonal subcortical heterotopia in the right parieto occipital region and temporal lobe. So again, this here you're able to appreciate it is following the signal of in all sequences. And another interesting thing we should have appreciated is there was also associated polymicrogyria. This is the normal gyral pattern as opposed to the abnormal gyral pattern. This is a polymicrogyria. And post contrast to just show you that there is no enhancement of the lesion and it is following the enhancement similar to the gray matter, which is again a solid evidence that it is what we are doing is definitely not with a mass and it is classical heterotopia. And the circle area which I am trying to show you is just a hippocampal rotation. It's a controversial entity. It may not contribute to any seizures, but however, it is better to document it. And you are also seeing some amount of temporal horn dilatation. And here there are two findings. One is the torque phenomenon. What is torque? Torque is nothing but normally in the development, one side of the brain twists over the other side. So frontal lobe appears to be twisted to anteriorly. So in this case, there is a torque and definitely there is torque law also you're able to appreciate it is not in the midline, it is more towards right side. So this is called torque phenomenon. It is good to report and document torque phenomenon. And the last but not the least important finding is patient also had some amount of perinatal hypoxia and there is amount of PVL. So ultimately, so finally, in our case, what are all there? There was a large heterotopic rest of gray matter and there was, again, you could appreciate there was a polymicrogyria and also hippocampal malrotation and there is PVL, periventricular leukomalacia, and also torque phenomenon. So all these findings, so they should not be syndrome of satisfaction. You should try to write all the findings and document everything. So that is how we have to, we never know what is the exact cause for the seizures or acute episode of the seizures in this case. So let me confine my topic to heterotopias in this. So heterotopias based on locations, they can be classified into periventricular, subcortical band types, and also nodular based on their appearance, curvilinear, giant, and all. Heterotopias again are the closest to differential diagnosis in tuberous sclerosis. You should not confuse them with subependymal nodules. Generally, subependymal nodules can show calcification and they may show enhancement in 10 to 25% of the patients, which is unlikely in the case it follows entirely gray matter signal. So a small foci in the ventricular region commonly seen. So this is called heterotopia. Very commonly, we have observed heterotopias which are often missed at the atrium of the ventricles in the peritrigonal region, one of the commonest location. Always look at in seizure patient, you should always see, and also in the frontal region. So in the body, naturally we tend to pick, but however in the areas where they're there, we may miss them. The subcortical heterotopia is our case where you have seen such a large mass-like thing. We have many cases of subcortical heterotopias, mostly reported as somewhere it's gliomas and they're on follow-up and all. That can happen. And we should prevent biopsy for such cases. Your knowledge will be tested about in such cases. And also we have kept on the band heterotopia. We have a video and listen carefully. So classical band heterotopia where the arrest will happen symmetrically and you will see a beautiful band like heterotopia. So finally, to conclude, proliferative phase, when there is decreased proliferation, you get microlissencephaly. When there is increased proliferation, you get hemimegalencephaly. When there is abnormal proliferation, you get FCD, focal cortical dysplasia. Under migration, you get complete lissencephaly. Over migration, you get congenital muscular dystrophy like Fukuyama dystrophy. Ectopic migration, you get heterotopia. And we had, in this case, we have migrational and organizational abnormality. Both were there, polymicrogyria and all. We should always check for the torch panel. Congenitally, torch is one reason, and perinatal hypoxia is one reason where you can get all these things. Thank you very much. Hope this video on interesting seizure case was useful for you.